Dr. Zeinab Alloub. She is a consultant neurodevelopmental pediatrician at Jalila Hospital, specialty hospital. She is graduated from Ain Shams University, Cairo, and she completed the pediatric postgraduate training and specialization in UK. Please let me welcome Dr. Zeinab Alloub.
Thank you, Dala. Thank you so much for this kind introduction. And I would like to thank Dr. Tariq for inviting me to this prestigious conference. And as well, I would like to thank very much Jester for making it a smooth journey to come here. And really, most of all, I would like to thank Dr. Tariq for letting me touch base with dear colleagues and friends from Abu Dhabi, with whom I had memorable years that I will treasure forever. So it's an honor to be here, and I have nothing to declare. And over the next 25 minutes, I'll be talking to you about ADHD, which is the most widely researched topic in children, neurodevelopmental disorders, and it's also the most success story of treatment in modern psychiatry and neurodevelopmental disorders. Yet, there is a lot of controversy and confusion about the diagnosis of ADHD to the publics, to the parent, and to the teachers, and to the professional. So what I would like, since it is a disability conference, I would like to address the disability aspect of ADHD. So what lies behind these apparently physically able children and their families? What does ADHD cause to the life? How does it impact it? And what is the quality of life of having a child with ADHD? So why do we need to know about ADHD? It is common. It cuts across all geographical areas, races, socioeconomic status. It can be serious, and I will take you through over the next slides. It persists. So the idea that it is burnt off, that children outgrow their ADHD, is not always there. It is stigmatizing. So ADHD, children out of order, can make the most competent parents really bad parents, or appear they're being judged, or it is bad parenting. Do not assume this. And it is stigmatizing. So out of the difficulties that these children pose to their families, they tend to be socially excluded. Even in intimate family gatherings, don't come, your children are bad news, they mess everything, they break, they whatever. And it's even double whammy, if the father as well. So the whole family, ADHD creates havoc around it. So, and then one other thing, it is treatable. That's the most important thing. It's the most treatable. As you have read throughout the whole day, we have heard that we are trying to get the disorders that are treatable. ADHD is a treatable condition using evidence-based evidence, criteria and effective treatment as well. So again, the behavior, what I would like to elaborate upon, it is behavior that is bad. And this is what we would like to modify, not the child. So there is a difference. Bad behavior is not synonymous with a bad child. So this is the impact of an untreated or undermeasured ADHD. So you have on the family, the high rate of parental divorce, there's inconsistency, they create havoc and between the parents. The mother all day has got arguing with the child, and then the father will come, there is inconsistency, there is leniency, so there is lack of discipline, and the children are very smart and they know how to press the breast buttons and then make the parents go together, get into conflict, and they come out. So the stress and frustration of a family with ADHD is actually superior to the more than the family with Down syndrome. Okay, extreme sibling fights, on the healthcare, bike accidents, ER emergency visits, and motorbikes, and the injuries are more severe, necessitating intensive care or more lengths of stay for the treatment. In the society, there are increased risk of substance abuse, maybe alcohol, drugs, or tobacco, less likely to quit, and they engage because of the lack of thinking of the consequence, premature sexual activity with unwanted pregnancy and sexually transmitted diseases, and yet do exist in our part of the world. So it's not that it is not reported that we don't have it, it is there. And of course, the education and the employment, these children are being expelled, they drop out of education, and hence later on, they will have problems with their employment. ADHD affects all domain of life. Wake up in the morning, the child is in fourth gear, getting ready to school. Everybody's in the house is ready. The child is not ready. Where is your shoes? Where is this? Every mother is screaming, we've got work. That other children, a lot of havoc. Going to school, he's permanently picked out. He's disruptive to the class. Everybody is singling him out, and he's labeled either the naughty of the class or the clown of the class. And difficulty with friendship. Now, children with ADHD, in their quest to have friends, they end up with the wrong crowd. And this is something very important. So when we start the effective treatment or whatever the management strategy, the first thing, of course, the parents and the school is their grades. But for the child, it is the social. I've made friends. I was invited to a birthday party. I was called on the team, which is most important for the child. After school, it is a nightmare as well, because this child is not winding down. It is just ongoing. Before sleep, everybody khalas, and he's still on the fourth gear, cannot settle down to sleep. Now, this cartoon, I like it very much because I show the family that ADHD starts small, but if you don't look after it or manage the child, it will end up like as big as like that. And so sometimes I give it a simile to the family. You can have a 6-year-old who's broken his leg, okay? And you're not going to plaster his leg. That's fine. Or put in a cast. The child will walk, but later on, he will have a limp. You will not correct because you didn't do it at the right time. And moreover, you go to the doctor and nothing is there. You look at where is the disability? There is nothing. You do a full physical exam. There is nothing to find in children with ADHD. And if the child comes with the iPad or the iPhone or a toy, in our hospital, we have a toy store. The children come, they make a problem, they give them a toy. Come into the clinic with the toy. Now, somebody like me, how I'm going to compete with a toy that the child has in his hand? So the child is concentrating, the child is doing very well, and many of the doctors will say, oh, there's nothing there, the child is concentrating, and there is no problem. Now, the worldwide prevalence of ADHD is about 5.2, and it is not before. It was called the westernization or the Americanization culture. This is no longer the case. These are world studies. For the sake of time, I will rush some. This was a study, was done at Alloub by Dr. Valza Epen before she's left to Australia, and it works as about 5% for school-age children. So if the UA population is quite young, yes, not geriatrics. So I worked out with a bit of math, 5% will be about 62,000 children every single day getting ready, going to school. So what is ADHD? So this is a huge number, and I'm sure not all these children, there are not enough professionals to cater for all these children. Understanding ADHD. What is ADHD? ADHD belongs to the group of neurodevelopmental disorders. So it follows all the rules. It's a neurocognitive, it has a neurocognitive basis, male predominance, ratio 4:1, like all neurodevelopmental disorders. It frequently coexists. Genetic influence is very strong. It's early onset, and it's here to stay. So it's not that you're going to treat and then it's going to disappear. And it continues, and no definitive cure. Where is the problem? We need to see where is the functional impairment. Does these problems cause functional impairment? Then yes, we have a diagnosis. So what is ADHD? It is a developmental disorder, age inappropriate. So it's age inappropriate in two domains. This is the inattention, the hyperactivity, and the impulsivity. So whilst shade of these three symptoms occur in typically developing children, where is the key operative diagnosis, qualifier? It is based on the careful evaluation of symptoms that cause problems or inappropriate problems with the school, with the family, and with the child himself, with his development. The child is not preventing a child from achieving. Do we have any test of inappropriateness? So we need to carefully evaluate the symptoms that are maladaptive and inconsistent with a child developmental level. So a 3-year-old can be hyperactive, not like a 7-year-old. So we're talking about age inappropriate. So Barkley's theory, Russell Barkley is a pioneer in ADHD, and he's a psychologist, and he's got a beautiful website for doctors, for parents. It's really very nice website. So it's not a problem with knowing what to do. It is the problem with doing what you know. I know how to do it, but I just can't get my mind to do it. That is the problem. It's not a matter of, it's a performance rather than knowledge. So executive function, where is the problem in ADHD? It is the executive function deficit. I like this cartoon and I share it with the family because it makes it easy. What is it? How to get to prioritize, how to get my focus, how my working memory would be okay, how will I avoid distraction, how will I avoid emotional regulation, so there is a lot of tasks that this is the executive function. It is the function in the prefrontal cortex in the brain. And there where the problem, the main problem with ADHD. So this inhibition is the hallmark of ADHD. The child not to not to walk, not to run around, to remain seated. He knows that he should remain seated, but he's unable. Yeah, he's able to focus, but he can't focus. So I also like this cartoon. It's like the executive function is like the air traffic control system in the brain. So when you show the family, you tell them exactly like it is. This is like the brain is telling him it's clear to do anything, but we know he's not able to channel the right information. He's not able to make use of what is being provided to him. So his brain is in a havoc state. And what we would like to do is to organize this. So what are the proposed etiology? Is it neuroanatomical, prefrontal cortex, neurochemical, dopamine, and norepinephrine, genetic origin? It is the top, and this is the proposed, I will have a slide about this. Environmental factors, they do not directly cause ADHD, but they affect the course, the expression, the comorbidity, and the severity, and the brain dysfunction during activation and inhibition. So this is the genetics of ADHD. It is, as it sees, it is highly heritable. So if you have a parent with ADHD, the risk is 50%. If you have a sibling, 41%, child, 25%. So in a family, you can imagine, and as we have said, males are more prominent. So you can see that there is a father with the siblings, the whole family will be all over the place, and the mother will just be living with this. It is sometimes can be quite hard. So we talk about vulnerability index and what are the protective environment factors, what are the environmental risks, genetic risks, medical risks, and the temperament. Temperament is very important. So when we talk about temperament of a child, this is what is the child behavior to start with? This is the innate. So it's nothing to do with you can be extrovert, I can be introvert, you're right, this is normal and this is normal. So if there's a mismatch between the temperament of the child and the mother, then this is not good news. So how do we diagnose? We said it is a neurobehavioral, neurodevelopmental disorder that is behaviorally defined. So we have to follow the DSM-5 criteria. For the sake of time, I will not be able to go through all this, but we have symptoms of inattention and symptoms of hyperactivity and impulsivity. So there should be a number of 6 of each over 6 period of time. The duration, it should be more than 6. Developmental, as I said, inconsistent with the child developmental level. Impairment, it must lead to, there must be impairment, and age happened before 12 years of age, and the situation in 2 or more. Now, the types of ADHD, it is either hyperactive, inattending, or combined. If the hyperactivity occurs most in boys, there are no learning difficulties. It's more behavioral with externalizing behavior as the comorbid. Inattention, more in girls, they have learning difficulties, and their comorbidities are internalizing problems like anxiety and depression and emotional liability. Combined is the most common. Now, comorbidities and ADHD, this is the rule. So comorbidity is like metastatic. You can't, it is seldom that you get ADHD on its own. Could it be psychiatric disorders, other associated mental health disorders? Top of the list is being ODD, oppositional defiant disorder, and followed by conduct disorder and so forth. And this is just how to see the association with ADHD is compared when with children without having ADHD, you can see how much the percentage skyrockets. You can also get comorbid developmental disorders. And this is a list I don't know whether to call it developmental differential diagnosis or not, but these are coexisting conditions. And I will not go for the sake of time to the list, but this is very important. You can see that ADHD really occurs with any single with a lot of conditions. May it be developmental, normal variation, and some other very important is the giftedness. So we get a lot of children, well, not a lot, but we do get, they hit our clinics that are gifted, but they are labeled as oppositional, rude, and not inattentive, because they're not streamlined to their abilities. So they feel everything is not being, they're not being nurtured in the right environment. The high-risk group, I will just mention, since we are in the disability conference, this epilepsy. In one of the studies from the Boston group, Hamouda, actually he doesn't, Hisham Hamouda, he comes visits UAE quite regularly. It goes up to 39%. So is it the effect of the anti-epileptic medication? Is it the effect of chronic seizures or subclinical epileptiform activities? Is it the adrenergic dysfunction, or is it the underlying condition or genetic that led to the same developmental vulnerability? Prematurity, very low birth weight and extremely low birth weight actually increases the risk by 300%. So we are getting children now that have post-cerebral palsy, and you see them 500 grams, 600 grams, and you look at them, wow, how are they doing? But then they're all over the place. So we don't discharge, even if you don't get CP, we are going to continue to see these children till we safely deliver them to school at 6 years. We will have before this ADHD precursor behavior. The other one is traumatic brain injury. It is a significant post-secondary ADHD up to 10 years. So these children, as they go into their adolescence and adulthood, they should be observed for their attention and their executive function. Now, this is a nice article, the timing of co-occurring chronic conditions in children with neurological impairment, of which this is a study that included 7,000 children with neurological impairment. CP was top of the list, the most number of the cases. And I wanted just to say that here, ADHD constituted about 10%, and the timing was about 4 years. Or 3.5, just under 4 years. So these children, we concentrate on the seizures, on the physical disability. We do not concentrate on the behavior. And here, we're not belittling about the physical, but if the child is not walking, or if the child is not, has got hypertonia, yes, it is the quality of life, it is affected, but it is the behavior that causes every single day in and out really very difficult for the Hani. It's going to be like living hell. So here, I would like to mention that we should describe the child. If I'm seeing a child with CP, with Pompe's, with whatever condition, do not forget the behavior. Describe the child. We talk about the motor, we talk about the speech and the cognition, and then we also should mention the behavior. Do not forget the behavior. We can do a lot so that the parents do not feel that they are being incompetent. And what happens over time? So I mentioned initially that ADHD is here to stay for a while. So the good news is that the hyperactivity reduces, the impulsivity reduces, but the attention continues. There will be progression of symptoms. So 2/3 carry it into adulthood. And the predictors of persistence will be the rule-breaking behavior. If the child is induced mainly conduct disorder, if it is familiar, if there is psychosocial adversity, and if there is psychiatric comorbidity.
5 minutes.
Okay, so screening for ADHD, we use the tools which are available. Vanderbilt, it depends upon the training and what does everybody have, and what is their practice. And it is available on the website. It's not copyrighted and in many languages. And just one thing about questionnaires, it helps the efficiency. It does not make a diagnosis. So still, like any other neurodevelopmental condition, our diagnosis is as good as our history. We need to take a very detailed developmental history. And now, as we have seen this morning, a lot of the children present with neurodevelopmental conditions, ADHD, autism, developmental delay, and can turn some to have something else. It can identify comorbidities and give parents an objective findings, and it yield information. We didn't get in the conversation. We always must assess the functional, as instead, what is the impact? And also this depends on the scale where you are being treated. Now, varying context, we should be aware that ADHD varies between in different, like in the clinic, you might not find ADHD, it varies. For the sake of time. So the assessment of ADHD is multimodal. We need to do a comprehensive, full. We must derobe the child, we show dysmorphism. We must derobe for any neurocutaneous markers. Many times we have derobed the child and we see the neurofibromatosis because they come to the doctor, and I'm not, criticizing, but we do get a lot of these children. And we must not forget to ask the child. You will going to hear these lovely stories from the children, and you will get the truth. They don't lie. So these children, they really will tell you what happened. Sometimes you see the end of the story, but you don't see the beginning of the story. And then the child will also explain the struggle. He goes from one thought to other. He can't concentrate. So this is quite exhaustive for the child. Yeah. And this is antimodal assessment. And so this is one of the occupational there. This is impulsivity, and the child I hold him and he just bit me. So this is a bite mark. Treatment for ADHD, it is the diagnosis, education, and there's American guidelines, and there are NICE guidelines. And ADHD is one of the few conditions that you cannot diagnose nor treat without having therapeutic alliance with the school. The teachers are here, main. You cannot do it without the teachers and the parents. You, at the end of the day, get all the information and then try to get the right management. So treatment is individually planned. I'm finishing. It reduces symptoms and it improves educational outcome, and it should reduce the family and the school pressure. So these are the guidelines. And the psychopharmacology, we should use what is FDA approved for there. And actually, Ritalin is a back-to-school special in most of the clinics, and for the teachers and the parents. And here there is non-psychological treatments as well. We should not forget that. Parenting behavior interventions. If you can school, what can an educator do? It's a school-based interventions. There's got to be a lot of modification. Otherwise, how would you educate a child whose brain is like this? And on the other hand, how can parents do? How can you parent a child when the parents cannot discipline the child, cannot understand the consequence? A child cannot, everything is now. He must have no inability to wait, he's impatient, so this is quite difficult. So there are parenting strategies, there are home-based modification treatment. And I'm sure it's the last two slides. ADHD is a serious public concern concerning its prevalence, its impairment it causes, its treatment effectiveness, and its chronicity. And I wanted to end up with this, that we should having ADHD is exactly the same as having a broken limb. You cannot tell a child who's got a broken leg to work harder. Okay, and these are my references. So, now the age of medication children is becoming less and less and less by many of our doctors, and this is just there. So read this. So you're expecting, why are you taking Ritalin? The baby's taking Ritalin.